We'll start.
Fine with me.
Yeah, once again, a very good morning and good morning to Professor Gordan and a good evening to all the participants who are here. And today happens to be an auspicious day for us. It is Doctors' Day in India, National Doctors' Day in India. And on this auspicious occasion, we have something good feast for the doctors. And at this point of time, as head of the institution, I have a privilege of welcoming Professor Gordan. This is the second time for the AVMC FFF platform, and I welcome him on behalf of the university, on behalf of the management. And this session is a follow-up session for the Golden Jubilee memorable webinar he delivered on 21st May, the past, present, and future of EBM. And it was, that time it was attended by around 700 participants, and so many questions were there. And some of the questions could not be taken by Professor Gordan. And this was indeed nice of him. He has accepted our invitation to be for this session to exclusively answer to the queries of this very important topic or important paradigm or important aid for the medical fraternity, that is evidence-based medicine. And we have received, when we have opened the registration almost 3 weeks back, now at the moment we have received around more than 150 questions, again Herculean task. The organizing team has categorized them, classified them, and some very good, excellent questions, totally unrelated. The topics were there. We have tried to avoid them, and we have arranged them in a sequential manner so that the discussion and the thought process of every one of us will go in a very smooth way. With these few words, I will request my colleague, Professor Mahalakshmi, to begin the session by putting on the questions to Professor Gordan. And she will be sharing the questions because that will be a good thing. Until he reads the question, they will be there. Over to you, Mahalakshmi.
Thank you very much, Prof. Kotur. We welcome you all for this program. We'll start. Dr. Gordan, I'll be projecting the questions, and then once you start answering, I will leave you to take that stage. That's how it is going to work.
Sorry, what do you mean, leave me to take the stage? I mean, I'll answer the question, but
you will be answering questions. That time I will stop the PowerPoint. People will be able to see you.
Okay, all right, I get it.
They won't be seeing the slide, so that's what I meant.
I get it. Okay, thank you. Okay, let's begin. This is the first question. What is the impact of practice of EBM over the last 3 decades? And we know, and you as the champion of EBM, the person who has introduced EBM into the medical curriculum, what do you think that the practice of EBM has left as an impact on current medical education? What have we achieved? This is the question from Professor of Ophthalmology, Dr. Kanmani from Chennai. So, well, I can answer that most authoritatively with respect to North America. And it may be that some of you could answer the question better. In fact, almost certainly, some of you could answer the question better with respect to India. And I have some notion of other parts of the world, which I'll mention, but I can speak authoritatively about North America. So in North America, it's been quite a while now that the licensing bodies for both undergraduate and postgraduate medical education demand an EBM curriculum. And so when the process of the licensing bodies coming around to see if they're going to approve either undergraduate medical programs or residency programs, they say, what are you doing in your EBM curriculum? In the same way, what are you doing with teaching physical examination? What are you doing with teaching physiology? What are you doing with teaching laboratory, and so on and so forth? So it's really recognized as an essential part of the core. And every institution in both undergraduate and postgraduate medicine
has to have an EBM program. And that's happened not only in medicine, but I know it a little less well, but it has also happened in allied health professionals. So it's happened in nursing, it's happened in the rehabilitation sciences, where evidence-based nursing or evidence-based rehabilitation science is part of the core curriculum. And then often a driver of these things is what happens in their examinations. So the examinations, whatever, will always have EBM components, and that encourages the students to learn it as well. So with respect to North America, it is now well established as a core part of medical and other health sciences training. The impression I have is that it is not it is not integrated to the same extent outside of North America. So it seems, my impression, and it's just an impression, is it's much more institution specific. So in India and Pakistan, for instance, which I have prior to COVID had the pleasure of visiting several times, I would have the impressions that particular institutions, and perhaps your institution is one of them, are taking leadership roles in evidence-based medicine education, but there are other places where not very much is happening. So in summary, for pretty close to a couple of decades now, a core part of medical education, and indeed health sciences education in North America, standard part of the curriculum, everybody's got to learn something. Other parts of the world, I know less, but the impression is it's sort of, there are enthusiasts everywhere, but it's not, it hasn't been implemented in the same core way in many places as it has in North America.
Thank you. You spoke about North America, but what about Australia, United Kingdom, and other well-established westernized nations? Do they also follow EBM, or they are with us?
Well, it's a good question, and it testifies to my I have lots of colleagues in both places, but I've never asked the questions that would allow me to give a definitive answer. So the people I interact with in Australia and the UK are, of course, enthusiasts in evidence-based medicine. That's who I talk to. And they're in all the places that I talk to, their institutions are doing a lot of EBM education. But I have to, when you ask the question, I realize I've never asked them, well, is it part of the licensing requirements? Is it demanded by the people who oversee residency and undergraduate medical education, for instance, the way it is in North America, that you have to, that every program has to do it? My impression is the answer is probably yes, because certainly there's a tremendous amount of EBM activity going on in both Australia and the UK. But whether it is now, the big step in North America was when the licensing bodies and the regulatory agencies said, this has to be part of the core curriculum. That's the big step. And whether that has happened in the UK or Australia, I am not sure.
Thank you, Gordan. One more annexure to this question. The WFME has come up with a lot of new guidelines for medical institutions to be accredited and standardized. The World Federation of Medical Education has come up with the new set of guidelines, quality mandate for medical colleges. Do you think that pushing this matter into WFME is going to take this forward across the world in a uniform way?
Well, what you are a sad, excuse me, a sad story, sorry, a sad story for this morning. I'm sorry. A sad story for this morning may be we'll find out just how narrow my perspective is in some way and my limitations, because the line of questioning reveals that I've not taken a major interest in monitoring exactly what is happening in medical education anywhere. It's just impressions that I've picked up. That's all I can offer. So the answer to your question is it sounds like that would be a great opportunity for EBM, but I have no idea what's happening at the moment or what the potential is for the future. Sorry.
Thank you very much. It was not.
You will be happy to know that our Indian Regulating Council, World Medical Council of India, has introduced recently, though, both at the undergraduate level as well as the postgraduate level, this evidence base, which has appeared in the new regulations. So I thought you should be happy to know that.
Well, that's the big step. The big step is when the regulatory bodies say this has to be part of the education.
Yes.
That is, to use the phrase that we use, that's the game changer of getting everybody to have to pay attention.
Yes.
Thank you, Dr. Gordan. I'll move on to the next question. This question is a very interesting question from Dr. Prashant. Dr. Prashant is an anesthetist from our college, and one Mrs. Beena Verma, a nurse from Kerala. Both of them have asked this question. There are a lot of lifestyle, racial, geographic, and other variations between populations. How can the evidence generated from one group be applicable universally to all? The paraphrasing of it is the given evidence really unbiased or best? How do we know this?
Well, those seem like two different questions. I'll try to point out why I think answer them each and point out why I think they're different. So first of all, let us start with interventions like drugs that where the general theme most clearly applicable to things like drugs or surgical procedures is the biology different? So for instance, the many drugs we have for cardiovascular, is the biology of atherosclerosis different in people of African heritage or people of Northern European heritage or people of Asian heritage? And the answer is, I think, in most cases, no. And that would be true for cardiovascular or for diabetes or for arthritis, for virtually anything. The biology does not differ substantially across racial groups. And as a result, when anybody looks for subgroups, subgroup effects, when you do the big trials and you have enough people, and more, well, many trials are now international, involving many countries, sometimes as many as 200 individual centers. And when people look across racial groups, they never find any subgroup effects. And that's because the biology of most of the afflictions of humankind is similar across racial groups. And that means that drugs act in the same way. Now, so that's the first thing. The applicability is, in most cases, the way you have to think about conceptually is the underlying biology of the illness different across racial groups? And the answer overwhelmingly is no. Now, if you get into behavioral interventions, where culture and background may have big influences on how people react to behavioral interventions, then it may be a different story. Not much less has been, at least what I'm familiar with, much less has been done in this area. Behavioral interventions tend to be introduced locally, geographically, and not necessarily to be widely the case. But one might at least suspect that there are going to be differences in how populations, excuse me, in how populations react to behavioral interventions according to their cultural backgrounds. Now, on the other hand, one behavioral area that I know a little bit about is cognitive behavioral therapy for depression. And cognitive behavioral therapy for depression has seemed to work across at least various jurisdictions. So it seems to work the same in Japan as it does in North America, for instance. So bottom lines are, the question is where one can identify the biological basis on which a medication is acting, then the question is, does that biologic basis differ across groups, racial groups? And the answer is no, it doesn't. So for almost anything, the drugs that we use for the common human diseases and illnesses, they will apply universally. With respect to behavioral interventions, you have to look at the local culture and see, is there something different in the local cultures that's liable to have a different effect? And that, to me, although the evidence is limited, it seems to me at least plausible that it's much more likely you're going to have different effects across regions because of different culture when you're talking about behavioral interventions. Now, the second part is referred to bias. And we think it's important to differentiate between bias and applicability. The first question was about applicability. So we could do a randomized trial where it is concealed, blinded, and 100% follow-up, clearly unbiased for its setting, but conceivably it may not apply to another setting. And certainly we see, let's take, for example, pediatrics. Many conditions have not been studied in pediatrics the way they have in adults. A trial may have been done in adults, which is extremely well done, gives an unbiased estimate, but does it apply to children? Quite possibly not. The issue is not bias with respect to the children, it is the applicability of the unbiased result in one population to another population. So the way I would frame the original question was, are the results, if one has an unbiased study, gives trustworthy results in one population, can you apply it to another population across racial groups? I think the answer is yes. Not only if it's been unbiased in one place, it probably applies to another place as well for almost all of our drug treatments. So I'm labeling the distinction between bias, which is systematic deviation from the truth, and applicability, that an unbiased results in one population may not apply to another population. That's not bias, that's the issue of applicability.
Thank you, Dr. Gordan, for a very succinct answer. I'll move on to the next question. The next question, since we discussed about cultural differences between populations, the next question is bordering on the cultural differences. The question is, what roles do patients' preferences and values and the clinicians' experiences and biases play in EBM paradigm? The most prominent example we saw is with regard to vaccine hesitancy, not only from our patients and population, but also from physicians. Many of my colleagues refused to take the vaccine when it was first introduced for the COVID. The second one is in many cultures, physicians are designated the role of surrogate decision makers. Paternalism is very obvious. You know what is best for me. So please advise or please take the necessary steps to correct the disease or disability for me. So how do we incorporate the stakeholders uh, uh, and also the context in synthesizing the evidence?
Vaccine hesitancy is a good example of different values and preferences. And it sounds like in India you are having the same experiences we're having here, in that one of the interesting things that has been observed in North America, well, in the United States, states that voted for then President Trump have much more vaccine hesitancy than states that voted for Mr. Biden. So you actually have a cultural difference with respect to vaccine hesitancy in the United States, depending on your political leanings. And that shows that, that's one vivid example where definitely values and preferences differ across cultures. They will differ across age groups, sometimes differ across sexes. That means, and it's a core principle of EBM, that with the same evidence, the right decision for one patient will be the wrong decision for another patient. And that means that if one in a parental view of practice, I know what's best for all my patients. I'll step back for a second. One can distinguish between some interventions, not that many of them, but some interventions are not value and preference sensitive. To take an extreme example, somebody comes to an emergency room with a myocardial infarction. It is not a sensible thing to start having a conversation about whether they should have an aspirin or not. Why not? Because the benefits are enormous relative to the downsides, which are negligible. So there are some interventions where the benefits are so much greater than the downsides, or vice versa, but it's not value and preference sensitive. Everybody, and another way to put that is if you did go through a shared decision-making exercise, everybody or almost everybody would choose the same thing. That's not a value and preference sensitive decision. On the other hand, taking the vaccine, one could, in terms of the value and preferences, I'll raise another issue. We usually talk about fully and appropriately informed individuals. So one reason that you may have apparent difference in values and preferences, which aren't really different values and preferences, is people have different idea about the benefits and harms, right? If one person thinks that the evidence indicates that the benefits are great and the harms are minimal, they'll be enthusiastic. Another person with the same values and preferences who has been informed differently and thinks the benefits of the intervention are not much and the harms are a lot more would make a different choice. There, it's not a difference in values and preferences, it's a difference in what people have been informed or what their beliefs are. Now, I don't know how much it's been studied. I certainly, if it has, I haven't looked at it. But one question would be, the people who are enthusiastic about the vaccines or people who are unenthusiastic about the vaccines, is it that their notions of the evidence are different, or is it that their values or preferences are different? The obvious values and preferences, the obvious value and preference difference would be how much you value prevention of a COVID infection versus how much you value avoiding the adverse effects. And we know for one of the vaccines that it really does cause cerebral vein thrombosis, and it's really bad news if you get cerebral vein thrombosis. On the other hand, it's extremely infrequent. So, there's when somebody says yes to the vaccine, somebody says no, there would be two possibilities. One possibility is that the person says yes, puts a higher value on preventing COVID and isn't too worried about the adverse effects of the vaccine. The individual who says no puts a much lower value in avoiding COVID and a much higher value on avoiding the adverse effects of the vaccine. That would be a value and preference difference. On the other hand, maybe one might speculate the people who are saying no to the vaccine actually have a distorted understanding of the evidence. They think that the adverse effects occur much more frequently than they really do. Then it's not a value and preference difference, it's a difference in their understanding of the evidence, where presumably somebody understands it correctly and somebody has a distorted impression of their evidence. So just to clarify that the two reasons two people might disagree, one says, yes, I want the vaccine, one doesn't. It could be a real difference in values and preferences, the relative value you put into benefits and harms, or it may be a different understanding of what the evidence is, in which case one would hope that one could get everybody to the same correct understanding of the evidence. Although we know there are people who will say, I don't care what you tell me, I know you're not telling me the truth about what the evidence is, and that's another problem. So that's general background of there are some, so to summarize, there are some decisions that are not value and preference sensitive when the benefits very much outweigh the downsides or vice versa. But there are many decisions that are value and preference sensitive, depending, for instance, on how you value the benefits versus how you value the downsides of the harms. And when we think of values and preferences, we always say the choices that would be made by fully and appropriately informed people, because if you're not appropriately informed about the benefits and harms, that brings in this other issue that I illustrated. So that's the general background. So now, one of the, when I'm, taking care of patients and teaching the house staff, a regular question that I will ask them is, we say, okay, should the patient receive X? I ask, is this a value and preference sensitive decision? So I'm always asking myself and asking my learners, is this a value and preference sensitive decision? If it's not, if we think that the benefits clearly outweigh the harms, we don't need to go through a full shared decision-making exercise. We have to, then you can just say to the patient, I think you should take this, here's the reason, this is the benefits, they're much greater than the harms, please go ahead. On the other hand, we say, this is a value and preference decision, and then we have to, then if the patient is going to get what is best for them, we have to know something about their values and preferences, either finding out and asking them about their values and preferences or engaging them in shared decision making. And we have we are also faced, although I suspect it's the parental approach to decision making is culturally much stronger in India than it is in my population, but we have it too. So the approach I take, and I'll tell you, give you a example and then state the principle. The last time I was in clinical service, I had an individual who had atrial fibrillation, CHADS4, so quite a high risk of stroke as a result of their atrial fibrillation, and was appropriately receiving anticoagulants. Patient came into the hospital with a hemoglobin of 5, very low hemoglobin, We transfused the patient up, searched for the source of it was clearly somewhere in the GI, but we couldn't figure it out. We couldn't find the source of the bleeding. So now bleeding settles down, patient is stable for a few days. We're not worried about ongoing bleeding. It seems to have stopped. And the question is, do we start anticoagulation now? Do we never restart anticoagulation? Do we start it later? Clearly, it struck me, this is a value and preference sensitive decision. So I went in and I had a conversation with the patient and the patient's wife, and the question, raised the issue, what shall we do about your anticoagulation? And the first response is, doctor, what do you think? What should we do? And I said, well, I could tell you what I would do in your position. Went through to make sure the patient understood what it is to have a stroke, could be mild or severe. And with respect to the GI bleeding, the patient had a very good understanding of what it's like to have a GI bleed, or at least the particular bleed that they had, not an acute overwhelming bleed, but rather it was some kind of slow leak. The patient understands what that's like. He's just been through it. So I say, clearly starting the anticoagulation will appreciably increase your risk of having a GI bleed, but it will decrease your risk of having a stroke. I said, for me, I am very stroke averse. A stroke for me would be a terrible thing, whereas the GI bleed, you get better. It's awful when you have it, but you get better. The stroke you live with indefinitely. So if it were me, I would restart the anticoagulants right away. Now, but that may not be right for you. If you are really worried about bleeding, if that would be terrible for you, you might want to wait. So that's how I handled the situation. Patient and the patient's spouse said, okay, we see it the way you do. This stroke sounds like bad news. We'll restart the anticoagulant right away. The principle of this is, when I am asked effectively, doctor, what is best? And it's a value and preference sensitive decision, I lay out, here are my values and preferences. With my values and preferences, this would be the right choice. If you share my values and preferences, it's also the right choice for you. But you may not share my values and preferences, and if so, a different choice would be better for you.
Thank you, Dr. Gordan. That was very, very nicely answered. And we have Dr. Pankaj from Chennai and Dr. Elshiba from Tiruvalla to thank for that very nice question. We were talking about value preferences versus evidence. So the next question is about evidence and what we do with the evidence. So this is the question for you. Why is it so difficult to follow evidence even after the literature suggests answers? Many a times we know this classic example of triple vessel bypass, which used to CABG, which used to go on for forever in the 70s and 80s, whether you had one woman and very often, but it seems to be much more exaggerated during the current pandemic. So how do we ensure that this practice percolates among clinicians? And Dr. John from CMC Vellore, I think he's a psychiatrist, he wants to know, should we enforce evidence upon clinicians and how do we go about it?
I'm an evidence-based guy, so I always start when people ask me questions is, do I really understand the evidence? And my breadth, as you've already found out, is limited. And so what is the evidence regarding the answer to this question? Now, so I would be interested what enforce means. I don't know how you enforce evidence, but the question seems to have to do with behavior change. Okay, so there have been, I'm not an expert, but I have a reasonable familiarity with the behavior change literature. And there have been some hundreds of trials of behavior change strategies, which have been summarized in, Cochrane has a part of its database that is focused on behavior change strategies. My understanding of, there's a very substantial literature, and there's all sorts of behavioral change strategies. There's different types of educating people about the evidence. There is audit and feedback. You watch what the person does, you give them feedback. There are educational influentials. You go to a community and you find out who are the doctors that everybody listens to. You get them to start telling people the right thing, and so on. As it turns out, this literature is rather disappointing. First of all, no magic bullets. Each of these strategies, typically when they have an effect at all, they are a small effect. Second disappointment is that even when they have a small effect, it doesn't seem to be consistent. Sometimes it works, sometimes it doesn't work, and when it does work, the effects are small. Thirdly, the third disappointment, people can't seem to figure out when it works and when it doesn't. You take the same intervention, so you in different trials, sometimes it works, sometimes it doesn't. You try and figure out what are the common things about when it worked and when it doesn't work. Nothing seems to jump out at you. So in terms of behavior change, the tone of the question, or if I understood it correctly, is we seem to have a lot of difficulty getting doctors to do practice consistent with the evidence. Well, when you look at the literature, no wonder, because we don't have good behavioral change strategies that work consistently and that have large effects. So we're a little bit stuck. Now, however, I know one very effective, that I'm convinced of one very effective behavior change strategy. And that is what you pay for and what you don't pay for. So if the one way of stopping physicians from doing procedures that have no benefit and are harmful is you stop paying for it. That tends to be quite effective. And if people are underutilizing something, you may increase what you pay for people doing it. That is one. I think we have enough evidence out in the world that people respond to financial incentives. No doubt about that. The pay for performance movement is big in the United States. It can be very challenging. I'll give you an example. Of where people have started to institute this, but you have to be really careful how you do it, because it can give what we call perverse incentives. Think of the following. People are get extra money if they get the patient's hemoglobin A1C under 7. Probably you have to pick these right. Actually, the evidence in support of benefits of getting your hemoglobin A1C under or over 7 are not, there is good evidence, and the evidence is there's not much of an effect having somebody at 7.5 or 6.5. The benefits are minimal. So it may be misguided in the first place. And again, this is where you have expert communities that are resistant to the evidence. Okay, the endocrinologists all think, let's get the hemoglobin A1C down. The evidence supporting that is across the sort of thresholds they've chosen, suggests that the effects, if any, are small reduction in myocardial infarction, not much else. But they picked this. So now you have a patient who's at 7.2. You will get more money if you can get them to 6.8. But if you went to the patient and said, here's a new drug, I can get you down, your hemoglobin A1C down a little. The evidence is that the benefits are not much. What do you think? You want to pay for this drug? Do you want to endure its side effects? And the patient would say no. Except now the doctor won't get their increased money. So instead of shared decision making, the doctor may be tempted to say, here, your hemoglobin A1C is a bit high, take this drug. When a shared decision making exercise, the patient would have said, no, thank you. Now, somebody's hemoglobin A1C is 10. There have been no randomized trials of lowering it at 10, probably because at that level, it would be a really good idea to lower your hemoglobin A1C. That's high enough that it probably makes a difference to lower it substantially. Except the doctor knows we'll never get the patient under 7. It's impossible. No financial incentive, a inappropriate financial incentive to get the person from 7.2 to 6.8, and no financial incentive to get the person with a hemoglobin A1C of 10 down. Okay, so so definitely you pay people to do various things, they will happen. You don't pay them to do other things, it won't happen. But creating the appropriate financial incentives can be very challenging. And there's a risk of what people have called perverse financial incentives, that in fact, it's done well-intentioned, but the way it plays out is not the way one would intend. So bottom line of all that, number one, I'm not exactly sure what it means to enforce evidence. I don't think one could enforce behavior in some way, although very difficult for me anyway to imagine how you would enforce behavior in doctors other than have them worried about malpractice. The other thing is that perhaps a big part of the reason that we continue to see people practicing inconsistent with the evidence is that we don't have good behavioral change strategies. People have done a lot of work in randomized trials of behavioral change strategies. Nothing seems to work very well. It seems to be inconsistent. We don't understand well when it works and when it doesn't. Thirdly, there's one behavior change strategy that I think would work, which is what you pay for and what you don't pay for. And people have done pay for performance strategies, but sometimes they haven't done a very good job of picking them and of avoiding these perverse incentives, which if you set up a strategy and you get it wrong, it in fact doesn't reinforce the behavior you want, may reinforce behavior that's actually inconsistent with what you want.
Thank you very much.
I just like to make one comment. Behavioral change you can expect in anybody only if deep learning takes place. Without learning, you can't expect. No amount of force also can bring a change in the behavior. What do you think?
It depends what you mean by learning. Most of us in medical practice operate by patterns of practice. So if you're with a lot of people I work with, they say, okay, patient has coronary artery disease. We'll give statins, we'll give an antiplatelet agent, so on. You ask them, what is the evidence? They'll say, well, it seems to be a good idea, okay? Now, has this individual been educated? Well, they've been educated to know like coronary artery disease, statins, and an antiplatelet agent. They've been educated about that. So do you need to educate them beyond that? I don't know. Okay, so I would agree with you in education in general, but if you're just talking about behavior, at least in these, and this is particularly true for decisions that are not value and preference sensitive. Everybody who's had a myocardial infarction, the benefits of statins and antiplatelet agents clearly outweigh the downsides. If you took everybody through a shared decision-making exercise, they'd all say the same thing. Yes, please, I'd like to take a statin and I'd like to take an antiplatelet agent. On those things, all the clinician needs to know is coronary artery disease, statins, and antiplatelet agents. They don't have to know the evidence particularly because there's no need for shared decision making. Anyway, just so I agree with you about education, but to be aware that educating the evidence-based practice can happen, at least for certain behaviors, with minimal education. The person just has to know, for particularly decisions that are not value and preference sensitive, you see this, you do this. That's the education they need for those sort of decisions.
Okay. Very nicely answered, Dr. Gordan. And I think in that answer, what struck me was what you called as quote unquote expert resistant communities. And I think the next question is somewhat related to one such thing. Normally, when we ask, when we say that this is the evidence, the question is, what do you say that this cannot be the evidence? No? This Dr. Sri Ganesh from NIMHANS has asked this question. Absence of evidence is not evidence of absence of a disease, of a condition, of the treatment working, etc. So he has quoted the example of mucormycosis and COVID pandemic. So can you let us know what your thoughts on how to manage this situation?
Well,
Absence of evidence.
Yeah, I can do it in general. If you want me to answer mucormycosis and COVID, you're going to have to educate me because we don't see mucormycosis where I practice. But the general thing is absolutely right. So there are two things. Somebody has done a trial and failed to find a difference between intervention and control, and they conclude the intervention does not work. In many cases, the correct interpretation is not that the intervention does not work, that it is that we have failed to show that the intervention works. And that is particularly true when trials have been done, but they're very small sample sizes. So with a failure to show a difference, there may be, the term people use is underpowered. You don't have enough patients to show a difference. You fail to show a difference. The only thing you conclude is that you failed to show a difference. So that's an important absence of evidence isn't evidence of absence. To show that something is really ineffective, you typically need large trials because patients tend to value small benefits, and to exclude a small benefit, you really need a lot of sample size. So that's a situation where you have trials and you're still not sure. Or you don't have the trials at all. You only have observational studies with low quality evidence or very low quality evidence, or sometimes you might just have a case series or individuals' reports of their experience. So what do you do under these circumstances? Extremely value and preference sensitive. So all sorts of situations, we have possible interventions that do not work, that we don't know whether they work or not. They might. There's biology that suggests they might work. There's speculation. Maybe somebody's tried it in a case series that looks like maybe it has an effect, but we really don't know. In these situations, the decisions are very value and preference sensitive. So the way one would generally characterize the situation, how much do we value speculative benefits maybe, but it's speculative that they benefit versus known burdens and harms. Okay, so there's very little that we give out to people that has no burden and no harm. And often with the treatments for, when we apply, so for instance, COVID, there's all sorts of treatments that have been used elsewhere, of which a dramatic example is ivermectin, which is very, very, very widely used. We know about its adverse effects. You'd expect the adverse effects, even this may not be quite right, but very often you expect the adverse effects to be similar in the new population as the old population. But at any rate, so there's almost certainly going to be some harms. We may have a good idea of what they are. There's going to be a burden. There's going to be a cost against unknown benefit. So the question is, how much do you value a speculative benefit versus the harms, burdens, and costs, which are in general less speculative? Nobody can tell you the right answer, right? In this sort of situation, I think there's little doubt that people's values and preferences differ. Some people will say, "Oh, it might work, doctor. Well, I'm not too worried about these adverse effects. I can pay for it. I don't mind taking pills. Let's give it a try." Somebody else says, "You don't know if it works, and there's a burden, there's a cost, I might have adverse effects. Sorry, that does not seem like a good deal to me." So the bottom line when we don't know is those are situations that are very, very, very frequently value and preference sensitive, and it has to do with the relative value we place on speculative benefits versus often less speculative burdens, costs, and harms.
Thank you. I think the key word you had used is speculative benefits. And I think the next question is related to that. Is speculative benefit the same as physician bias? I think that's a question from Dr. Kotur. I can put that question. Yeah. The translation of evidence into practice is fraught with challenges. How do we balance evidence against bias? At one end is this push by the pharma industries to publish results which are beneficial to them. The other end, we have economically challenged countries where practice of evidence-based medicine or evidence-based clinical practice may not be feasible. So how do we bridge this gap? Do we really need more independent efforts to build EBM?
Well, we educate our clinicians not to listen to the pharmaceutical industry. That is a poor source of guidance. And one of the things that's happened over the last 20 or 30 years is the profusion of clinical practice guidelines which have come out, which come from various sources. And the other thing that's happened over those last 20 or 30 years is not only the profusion of guidelines, but standards for trustworthy guidelines. And so if you look at the guidelines from 15 or 20 years ago, the guideline panels were all made up of experts who were often taking large amounts of money from the pharmaceutical industry. And so so even if you just didn't listen to the advertising directly from the industry had its ways of influencing things by essentially paying off the experts, which still goes on a lot. However, there have been moves to, there have been standards promulgated for trustworthy guidelines, one of which is effective management of conflict of interest, which is still a struggle and variable, but there are sources that are much better versus not so good about that conflict of interest. And certainly you still have the leading experts in almost every area where there's a drug receive money from the companies. And that's smart. That's smart behavior on the part of the companies. Somebody's an authority. You want them to say, oh, this drug is good. What's one good way to do it? In one way or another, get them to accept large amounts of money from you. That will definitely encourage them. That will very likely be effective in getting them to be more enthusiastic about your drug than they otherwise would be. So bottom line of that is I should say, obviously, the pharmaceutical industry has done wonderful things for humankind. We have many drugs that have made a huge difference, positive difference to people's lives. But we certainly have situations where they're overused or inappropriately used because of the financial incentives in some way or other to get physicians to use things when it might not be the best thing to do. So bottom line of all that is there are more and more, there are sources that are relatively free anyway of the pharmaceutical financial influence, and we need to direct clinicians to those resources for guidance as how to practice and direct them away from certainly the direct influence of the pharmaceutical industry, but even also the indirect influence of the pharmaceutical industry when leading experts have received large amounts of money. So that is one part. I'm trying to remember, there were several parts to the question. It is, well, I'll remember one more, and then if I've forgotten some, well, you bring it right back. Biased, okay, I've dealt with bias by the pharma. Economic where evidence-based medicine may not be feasible. Well, I would argue it depends how you define evidence-based clinical practice. Now, in many ways, everyone on this call is better equipped to talk about resource-constrained environments than I am. Why? Because I live and practice in an environment where there are, we actually practice different from the States, from the US, in terms of we take a different, well, I'll step back again. I live in a minimally resource-constrained environment. Everybody on this call lives in a much more resource-constrained environment. So how come I'm telling you who don't have the experience, and telling you who do have the experience about what you should do about your resource-constrained environments? Well, maybe not the greatest idea. However, I will comment. The statement was, we can't do evidence-based clinical practice in very resource-constrained environments. That seemed to be the implication. Not the way I see it. It is, if by evidence-based clinical practice it means you give patients anything that has ever been shown to have substantial benefits, well, you surely cannot do that in resource-constrained environments. On the other hand, evidence-based practice means doing the best you can with the resources that you have. And how can you do the best? Well, how does one decide how to do the best with one's in resource-constrained environments? then the evidence becomes even, one could argue, the evidence becomes even more important in making the judgment about where you put your resources as a society. And it actually comes back that there are what Canadians think are marginal gains at excessive cost. We don't do them in Canada. We're just across the border. They do them. Even though we are rich countries, we have somewhat different attitudes toward marginal gains with very large costs. So my point there is that evidence-based clinical practice doesn't mean do everything where there's any possible benefit, even if the costs are enormous. That's not evidence-based clinical practice. Evidence-based clinical practice is we all have limited resources. Even our high-income countries have limited resources, and evidence-based clinical practice is about using the evidence to use resources efficiently. So I can state that as a principle, and your answer may, I could easily imagine that somebody hearing this would say, yeah, Dr. Guy, that's a nice principle, but you have no clue about what it really is like in India and our resource constraints. And I'd say, that's right. I'm sure I don't have any idea because I'm not the one living and practicing in that environment. So all I can say is that in principle, evidence-based clinical practice in resource-constrained environments means looking carefully at the relative benefits, harms, costs, and putting your resources where the colloquial phrase is where you get the biggest bang for the buck. In other words, where you get the most benefit for your resource expenditure.
Yeah, thank you. I think the message we need to take is doing the best with what you have and try to generate evidence in the context in which we are practicing. So with that, I'll take the next question. The next question is from Dr. Joseph Philip, who is there in this meeting also. This is with regard to, this is what it is. What, in your opinion, has been the challenge of practice of EBM during the COVID pandemic? We have seen a lot of trials and errors. We have seen desperate measures, give plasma, then you give ivermectin, you then there is whatever measures were there, there was paucity of evidence. And whatever evidence was there, we did not know whether it was authentic or not. And the guidelines kept on changing every day, sometimes multiple times in a week, we used to get different SOPs. So these are all the things which happened during the COVID pandemic. So how do we actually do that? What do we do best with what we can have? So especially in the COVID time, the challenges of practicing EBM during the COVID time. And there is a corollary to that question. Is WHO really following evidence-based practice, or is it only advocating evidence-based practice? So that's a little loaded, I think, but this is a question from Dr. Joseph.
It's particularly, I'll start with that one and then go back. It's particularly loaded because I have an enormous conflict of interest on that issue, because I am working extremely closely with WHO to produce their guidelines for COVID. As a result, sorry?
No. Please go ahead, sir. Please go ahead. I muted. Dr. Gordan, you are muted. I'm sorry. I muted everyone. You also got muted.
Okay.
Yeah.
So I work very closely with the WHO. I'm very involved with their COVID guidelines. So I would hope that they're evidence-based, but maybe you shouldn't trust me because I work too closely with them. But at any rate, I'm doing my best, and I think we got a really good team. I think we got a really good team for WHO. So I think I'm happy with how it's going. But to return, so one of the problems has been, well, there's a couple of problems. One is there's something like over 2,000 randomized trials of COVID that have been launched, of which probably all but a few are not going to give any useful information. Poorly done and too small. And there are only a small number of high quality trials that are big enough, organized well enough that they give useful information. But that's on the one hand. On the other hand, the way things usually go, the evidence has been generated very quickly. And the evidence being generated very quickly, and not only that, that's one thing, the evidence has been generated very quickly, but also the internet, where historically people protect their data and they want to make sure they get the maximum credit and they won't share their thing. People have realized that this is a humanitarian crisis where those old ways of operating can't fall. So one of the great things being involved with the WHO has leverage. We can go to the trialists and say, okay, show us your data first. We prepare the guidelines. They make deals with them about making sure they get the appropriate credit, and we have to sometimes wait till the day of the publication, but we have the data before, so we're ready, so that as soon as the date of the publication, we can put out the guideline. Unfortunate EBM practice, everybody's starting their own little trial, which is not going to yield any results, where everybody should be pitching in and participating in the big international trials, things like the WHO Solidarity. Britain has done a wonderful job with recovery and so on. That's one thing. Secondly, no surprise that recommendations are changing when you have this fortunate, very rapid production of evidence. So at my institution, I'm involved in helping out with what we call a living network meta-analysis, where we just had a meeting of the group, and in the last month, we processed 40 randomized trials. In other words, we identified them. We're working very quickly. We've got a team working very quickly. We identify them. We assess their risk of bias. We abstract the data. We put it into the database. We update our network meta-analysis. And this is happening all the time with this very rapid production of evidence, which is a huge EBM success, that in fact we've produced the evidence so quickly. So no surprise that things change now. But we have had the problem that we talked about earlier in this conversation, which is the speculative benefits with known harms, burdens, and costs. It's been a huge issue, right? So people take really low or very low quality evidence and they say hydroxychloroquine is great. And you have various authority figures, including the then President of the United States, with no respect or understanding of evidence at all, who is one of those saying hydroxychloroquine is great. And so you have the advocates, and I believe there's ivermectin advocates, where WHO has looked at the ivermectin evidence and said this is not trustworthy evidence. We simply have to wait. But a guideline panel may legitimately make different recommendations, because one of the things we emphasize is guideline panels should make their values and preferences explicit. And so a guideline panel that says we put a high value on speculative benefits and we put a low value on limited known harms, burdens, and cost, and therefore we recommend in favor of this treatment. Another guideline panel looking at exactly the same evidence can say we put a low value on speculative benefits and a high value on avoiding harms, burdens, and costs when the evidence is only speculative. Our WHO, and this is my personal inclination, which the WHO has adopted, which is, I mean, I'm not saying they've adopted I'm not saying they've listened to me, but I'm saying my personal values and preferences are concordant with what WHO has adopted, which is the latter stance. So the basic WHO stance is we put a low value on speculative benefits and a high value of, in the context of speculative benefits, of avoiding unnecessary harms, cost, and burden. And so we looked at the ivermectin. Ivermectin is a good example of the application of that. We looked at the ivermectin evidence, and the WHO said it shouldn't be used outside of randomized trials. That's the only place it should be used. Well, somebody may say, but maybe it works. We don't. We're in the absence of evidence. We don't have it. The evidence isn't there that it doesn't work. And somebody may say, but it might work. Let's use it. Well, they're not wrong. They just have a different set of values and preferences. So I talked about standards of trustworthy guidelines. It's still, I think, much of the guideline expert community thinks that the explicit statement about your values and preferences is so crucial and still not done as well as it should be. If you look at the WHO guidelines, it says something to this effect. We think, we may be wrong, we think that patients will be reluctant to use treatments when there is only low or particularly very low quality of evidence of benefits and known harms, costs, and burdens, which there always are. We could be wrong. Maybe most people in the world would say, give me I don't care if you don't know if ivermectin works, give it to me because it might work. Maybe. However, the WHO guidelines explicitly state values and preferences, which is a low value on speculative benefits and a high value in avoiding the downsides when you don't have any benefit. Somebody with different values and preferences would not like the WHO recommendations, but it's explicit that they're based on those particular values and preferences. And so, so what's the poor clinician to do faced with different recommendations? Well, understanding why they might, going to authoritative presentations of the evidence. And, huge conflict of interest again, but our McMaster Living Network meta-analysis tells you everything. We're updating it all the time. That's one very good place to look for what the evidence is. And then once you know the evidence, does it fit with the guidelines? And then just the awareness that the same evidence with different values and preferences. Early on, I was told that in the Polish expert community and expert communities in general, in my impression, tend to put a higher value on speculative benefits from some physiologic rationale, for instance, than I would. So these Polish guidelines were give one drug, give one unproven drug. If the patient's not doing well, give a second unproven drug. If they're still not doing well, give a third unproven drug. And if they're still not doing well, give a fourth unproven drug. Where in Canada, we weren't giving any of them, right? Because in general, we were, in general, our community, and here again, you get the cross values of different cultural values and preferences, our community, maybe, I would hope to say, because of the extent of promulgation of EBM principles, is much more on the let's avoid the unnecessary harm, burden, and cost, and wait till we actually have some evidence of benefit before we give things out to people.
Yeah, thank you. That was very nicely answered. And we weren't putting a loaded question to just test you what your conflict of interest with WHO was. This is just, I think the question came from one of the participants.
Well, so it's just you're asked. So it's I'm really happy the way it's working. So we have a group that's involved with. There's a group I'm working with called Making Grade the Irresistible Choice, or MAGIC, which is a research group. There's our group at McMaster that's producing this living network meta-analysis. And there's a woman who's heading up the WHO effort on the COVID guidelines by the name of Janet Diaz. And we form a group together. We talk at least, typically we talk twice a week as a group. We plan the guidelines. We are the methods expert for the WHO guideline panels and work very closely together. So my impression is it's working quite nicely.
Thank you. The nice takeaway from that answer was what you told us about living network, where you are looking at evidence very critically and putting a lot
and
of.
I can send you the link. So we're going to have our own website, I'm told, in the next week or two. At the moment, this living network meta-analysis is published by the BMJ and can be accessed through the BMJ. And if you want, at the end, I can send you a link.
Yeah, thank you. I can share it with
and I can also send you a link to the WHO guidelines. They've got a nice link now. Finally, it took them a bit of a time, but they've got a nice link there too.
Yeah, taking on that living network analysis, what you were saying. So the next question is, we are using EBM mainly as a tool for translating research into practice. What else we can use, like what you told us just now, looks like a repurposing of EBM. So can we do any other, or can we find other potential uses for EBM other than looking at translating what clinical trials say to us into guidelines?
Well, it's to me, I'm not sure what you're thinking. It's all variations in translating evidence into practice. So one of the ironies of EBM, to me, is that a key EBM principle is evidence never makes decisions. It's always evidence in the context of values and preferences. And so it's ironic. If you think of our conversation over the last hour or whatever it's been, think of how much has been talked about values and preferences. We're talking about EBM, but in fact, half or more of what we talked about is values and preferences. And what EBM has done is provide the insight about how crucial values and preferences are. And frankly, before EBM, well, even at the beginning of EBM, if you read the first EBM stuff, the very first, back around early 90s, there's very little or no mention of values and preferences. What happened is we said, let's use the evidence. Here are the benefits, here's the downsides. Well, after doing that for a little while, you realize sometimes the benefits and downsides are, the benefits are much bigger than the downsides or vice versa, but very, very often they're more closely balanced. And as soon as they're more closely balanced, how do you make a decision? Well, the light bulb goes on and you say, it's a value and preference. It's how much you value the upsides, how much you value. So from the top at the start, it wasn't there, even in EBM. Within less than a decade, it became very prominent within EBM. So it's obviously part of the use. It's part of going from evidence to practice, but a use of EBM is to educate people on the importance of values and preferences. And then, in our view, as soon as you realize that, the importance of shared decision making. Because so many of our decisions are value and preference sensitive. And so a lot of work, the frontier of EBM is producing decision aids to help clinicians do shared decision making, and then to develop strategies. The one I've developed myself about trying to avoid parental approaches to decision making is to say, okay, here's what I would do, but here's my values and preferences that actually determine what I would do, and does this fit with yours? So I don't know if that's what the questioner was getting at with other uses of EBM, but that's what occurs to me.
Yeah, thank you. I think what came out was you said that it not only is used only for looking at evidence in context, and also teaching people to develop insight into patient values and preferences or value. That is what I think the use of EBM as a 21st century teaching tool, not only to teach clinical medicine, but also to teach, to look at human beings as a whole, or holistic medicine. That is, I think,
well, which is surely what clinical medicine should be about, no?
Yes, sir. I'll move on to the next question. This is from Dr. Swati Purna. She wants to know about what competencies can we foster by the practice of EBM. I think this is in the context of evidence competency-based medical approach, which has come up in a big way in many of the countries. And India is also one of the countries which has adopted the competency-based medical education, both for undergraduate as well as for residents. So in this context, what competencies are we fostering by the practice of EBM? Is it only the knowledge, or other things also we are fostering?
Okay, so now you come across another of my limitations. I am not that familiar with all these competencies. So if you asked me, Dr. Guy, please list the competencies in the thing, I would get a failing grade without a doubt. Okay. So so it's completely, but I do know there is something about professionalism. And in that broad category, the values, it's back to the values and preference stuff again, okay? So I would presume part of professionalism is being able to talk to your patients, and being aware that its decisions are value and preference sensitive, and somehow knowing how to ensure that the decisions are consistent with the individual patient values and preferences. And that clearly has to do with skills of how you interact with your patients. So there must be something in all these professional categories. I would think that that would be quite prominent, and EBM certainly informs that.
What about the critical thinking?
Yeah, well, critical thinking is obviously, so again, when you're faced with the evidence, people interpret the evidence differently. You go to experts, experts will disagree about the evidence, okay? So the evidence always involves interpretation. Now, most clinicians, very, very few clinicians are going to receive enough EBM training that they're able to process the evidence itself. So the critical thinking that you're going to have most clinicians do is not interpretation of the evidence. The critical thinking, I'm not sure what people mean by critical thinking, frankly, but the critical thinking that is crucial is to be able to understand the evidence. You find somebody who does a good job of summarizing the evidence for you, and then you use that evidence summary to consider the balance of benefits and harms. So clinicians, for instance, we need to do a better job of getting people to think, is a particular magnitude of effect a trivial effect, a small effect, a moderate effect, or a large effect? Because you need to have some notion of the magnitudes of effect when you are trading off. So the critical thinking as I say, I don't think it's realistic to expect clinicians to be the ones processing and interpreting the evidence, but the critical thinking they need is in finding somebody who can present evidence summaries that you believe, and then understanding that to move it to your clinical practice.
Thank you.
Apart
Since
from
we are talking,
thinking, excuse me, this is Dr. from Sydney, Australia. Can you hear me?
Yes.
Yeah, thank you. Apart from critical thinking, what about collateral thinking and lateral thinking?
Again, you hit on my limitations. I don't even know what collateral and lateral thinking is. So as a result, if I don't know what it is, I can't very well comment on it.
Thank you.
This is another use of EBM. You're talking about use of EBM. I have a slide that it says EBM, a fundamental EBM started with Confucius, and the Confucius is talking to one of his students, and he says, you know what it is to know when you know, and know when you don't know. And EBM gives you, so I'm well attuned. Somebody asked me a question, I know I don't know. I could just say, sorry, I don't know.
Yeah, Dr. Gordan, I must tell you that, not recently, almost 6-8 years back, we did a small study of early introduction of EBM to the medical students. Early, what I mean is during the first or second years of study. And we used one tool that was CCTD, California Critical Thinking Indisposition tool. And we found that the ability to think critically in the medicos was significantly enhanced pre and post.
Well, sounds like an encouraging result. I like it.
Yeah.
Yeah, I think Dr. Kotur has started the discussion on the next question I was about to put to you. This is from Dr. Narayan, who is a pediatrician from JIPMER. He wants to know, is the ability to think rationally and to analyze critically inbuilt into human beings? Oh, I'm sorry, I'm not sharing the slides. Or is it some trait which can be imparted by means of training? So is this a inherited trait, or is this something which can be cultivated or imparted by training?
The capacity to think rationally is intrinsic to human beings, but it requires training. So among the very interesting EBM work, a guy who trained with me a long time ago, but he was actually the guy who started GRADE. Andy Oxman, his work has moved to teaching grade school kids. And amazingly, he started in Africa, teaching grade school kids how to be critical about health claims, right? And he did a big randomized trial in schools in Uganda, I think mainly Uganda, maybe one or two other countries, of grade school kids, teaching them to be skeptical about health claims. And in the randomized trial, he showed that you can teach kids to be critical about health claims. And he laid out all the principles of what you would call, I guess, critical thinking about, when you're assessing a health claim, what do you have to think through? Obviously tied to EBM, but beyond EBM. And he was able to show a big effect of this training, published it in the Lancet. And interestingly, although there was no education directly at the parents, he gave the parents the same tests. And although the effect was smaller, the parents also became better at critical thinking about health claims. They were learning from the kids. So the bottom line is this is ideally, we would start what Andy Oxman has shown is that this is eminently teachable. It's eminently teachable at this right down to grade school. And that's when we should start teaching people. And then there'd be a lot less confusion down the road.
Okay. We'll move on to the next one. That was very nice answer. This is from Dr. Bhatt, who is there, who is our medical director. He's in this meeting. And sir has got a question. In case there is a conflict between evidence-based medicine and personalized medicine based on our genomics and others, what should we do? How does this conflict resolve?
Well, I would be interested in an example of a conflict. Questions like this, it's very hard. They are, I think, most informative. But I actually have a talk that says EVM is personalized medicine. That's the title of the talk. And so what do I say in the talk? I talk about that EBM looks for subgroup effects in relative effects. It looks for subgroup effects in absolute effects. When it finds them, it gives you a direction of how to process this thing. And the ultimate personalized medicine to me is what I've been saying many times during this conversation, is recognizing that evidence never makes decisions. It's evidence in the context of values and preferences, and how key it is. You want to get the decision right for an individual patient. You have to make sure that that decision is consistent with that person's values and preferences. This is the most personalized medicine. In terms of what interventions that may emerge from, for instance, genetic investigations, EBM has tools for evaluating that. It says, okay, has it been shown to actually benefit anybody? We have well worked out approaches to doing that. So I do not see, and maybe there is a conflict that I don't understand, quite possible. And whoever the question was, I'd be happy if they would explain it. I do not see a conflict.
But would you like to speak?
Often in question papers, you find this question between personalized medicine and evidence-based medicine. In students' question paper, often these questions finds a place. So I was thinking whether personal medicine is based on this genetic framework or something. So what is evidence may not be suitable for everybody. So evidence is based on the studies done, which may not be completely suitable for a particular person. Then it becomes not that we.
Right. So that's why I said in this talk about EBM as personalized medicine, EBM pays a lot of attention to subgroups, and it pays a lot of attention to subgroups in relative effect, and it pays a lot of attention to subgroups in absolute effects. And, you know, if some genetic test, as some of them limited, but some of them have clearly shown that people with that certain genetic markers influence your adverse effects with treatment and your benefits with treatment. And then that should be shown in appropriate studies. And when it's shown in appropriate studies, then that should be implemented in practice. When people presented as a juxtaposition of EBM versus personalized medicine, as far as I can tell, it's a profound misunderstanding of EBM, which has been there from the beginning. After 20 years where we've been pushing the values and preferences, and I told you our first articles, it wasn't there. After 20 years, we've been pushing values and preferences. Some people are still saying, oh, it's textbook medicine, or just following rules and so on and so forth. You know, they just don't, they apparently haven't read the material. And similarly, this juxtaposition as if there were a conflict between personalized and EBM has absolutely the framework to make sure that innovations introduced by personalized medicine, by the genetics, actually meet their claims. I don't think you would want to introduce things until you make sure that what they're telling you is right and that people benefit from it. And EBM has the tools to do that. So I don't see, and if you're talking about and again, maybe here's another misunderstanding of EBM. EBM is just randomized trials, okay? Completely not true. And in the grade framework, so, you know, one of the things we point out is there's all sorts of interventions like hip replacements or ventilation or dialysis or epinephrine or insulin, where we didn't need randomized trials because the effects are big enough. Some genetic thing comes along, and if somebody has this genetic and you give them a particular treatment, historically everybody died and now everybody lives for 10 years, you don't need a randomized trial. And EBM accommodates that. So I'm wondering, you know, this juxtaposition seems to me a fundamental misunderstanding of EBM. And then I'm thinking, why do they not understand? Because still, you know, grade has been around now for 20 years. And grade says, okay, randomized trials start at high quality evidence, but maybe low, and end up as low quality evidence. Observational studies start as low quality evidence, but may end up as high quality evidence, okay? You know, it's been out there for 20 years very explicitly. People seem to have not read the material or not get it. So that I have spared myself from reading the papers you're describing, but that would be, I'm guessing, it seems to me fundamentally the misunderstanding, and then I'm sort of speculating what the nature of the misunderstanding might be.
Yeah, we're talking a lot about generating evidence, and we keep looking at it. I'm going to skip a few of the questions because you have actually answered. So this is what it is. Like we are looking at RCT as the golden goose, right, for generating any evidence. But now it has been challenged by artificial intelligence, especially the big data which we are coming up with and the registries which are being developed. So how do you envisage the application of artificial intelligence on how EBM is going to go in future using artificial intelligence, especially the big data?
Okay. What is big data? Big data is observational studies, most often from administrative databases. You look at the quality of these administrative databases, many of them, probably all of them are limited. Many of them are very limited. They rely on what the physicians are putting into the database, which, if you contrast that of documentation in randomized trials, is problematic. And there's tons of studies showing that the quality of the data in the databases is sometimes limited. So you can't even trust it to be a little hyperbolic about it. You can't even trust the data in these databases to start with. But let's put that aside. They are just big observational studies, right? That's all they are, is big observational studies. And we know that when there are biases, you get biased results. With huge numbers, you get a nice narrow confidence interval around biased results. So just to pick one example, we had very large studies showing that antioxidant vitamins reduce cancer and heart disease. And it's true that people who take antioxidant vitamins do have less heart disease and do have less cancer. However, it has nothing to do with antioxidant vitamins. When the randomized trials are done, nothing, okay? So it so happens that people who take antioxidant vitamins are different from the people who don't take antioxidant vitamins, and that is what determines. It's the fundamental problem with confounding in observational studies. And big data, which has even problems, as I've just suggested, sometimes with the quality of data. But if we put that aside, big data does nothing to that problem with unmeasured confounding being that the groups who take the treatment are different from the groups who don't, and we're not sure why, and we haven't accurately measured the prognostic factors that make them different. That unmeasured confounding has not gone away just because you have the databases are large. Now, what it can do can be very helpful in generating prognostic models. So in terms of, large data is good for making up prognostic models. We should end up with better prognostic models from having large data. Now, so far, when you do conventional regression models versus the AI-developed prognostic models, so far, the AI-developed models don't seem to be systematically any better. The latest systematic review comparing them that I know of showed no difference in their predictive capacity. But the big data will help us generate, because it's big, it will help us generate better prognostic models. That's one definite role. And maybe the AI will work better than regression approaches. So far, not so clear that it will, but it may.
There is no evidence to show that AI works, right?
Well, no. The evidence thus far, when people have compared regression models to AI, is that the AI models do not consistently seem better. So it's not that their evidence is better, there's some evidence it's not better. We're back to the evidence of absence or absence of evidence. Here we have some evidence of absence as far as, I mean, I'm no expert And this was already a couple of years ago, and things the AI may prove better than the regression models over the long term, but so far not so clear.
Yeah. So that brings us to the most fundamental question. How do we take this message across to the people? We live in an era where the litigations are very high. We have the self-proclaimed Facebook and social media experts, I'm sorry. They are there in every nook and corner. They will look at everything what is being said and put up. So how do we tackle this? How do we go about educating the public about EBM and standards of care? What is the way forward in this condition? Because I remember that recently there was a big backlash against Dr. Perry Wilson, who's from Yale University, the nephrologist, when he was talking about some of the clinical trials which had come in the COVID era, and when he had put his comments. So everybody actually jumped on him and said, let's boycott what he says. So this is the phenomenon which we are witnessing in the recent times because of the power of social media.
Right. Okay. So here is where my training in evidence-based medicine helps me a lot in in a way that I described previously. And it goes back to Confucius' statement to his student about knowing what you know and knowing what you don't know. And because of how I've been trained to think, the first thing I think when you ask me that question is, what is the evidence about how best to deal with this problem? And my next thought is, if there's any evidence of how to deal with this problem, I don't know what it is. Okay. So now so first of all, you probably shouldn't be asking me because I don't know any evidence that bears on this issue. And you might say, Dr. Guy, even though there's no evidence, even though to put it in a colloquial way, even though you really don't know what you're talking about, why don't you speculate anyway? Okay. But I will tell you, most people, I believe, most people, when you listen, who haven't been trained in this, they don't immediately realize when there's evidence that they know and when there isn't. And they immediately start to speculate in a way that doesn't distinguish what is complete speculation from what is actually based on something. Anyway, so to start off with, in this matter, I have no particular authority because there's no evidence that I know of that bears on how we should deal with this. What we somehow, in principle, somehow we have to get people to distinguish between authoritative sources and non-authoritative sources. And to me, this goes back to Andy Oxman and his work showing that you can train grade school kids in evaluating health claims. The long-term solution to this problem is to get education about health claims. And Andy's he's worked out a curriculum for grade school kids. He's working out a curriculum for high school kids. We need, over the long-term solution to this problem is to have the education which Andy in his randomized trial has shown can be done even in grade school kids. We need to get this into the school systems so that people are trained right off the bat in skepticism and in fundamental principles of distinguishing what is true and what is not true. And having done that, they will, having been trained in that way, their first question when they see some claim will be, what is the basis of this? Where does it come from? And being able to distinguish between authoritative sources and misleading, misguided, and frankly suspect sources.
Yeah, thank you. So we need to search for the truth, right? Singularity.
Well, I think we can't.
Truth.
My impression is the principles again, although, as I said, evidence is, there's no evidence I know of. It's the best way of dealing with this new problem. But the principles are, people have to be able to distinguish between trustworthy sources and untrustworthy sources. That's a necessity. If you can't do that, then you're lost. And so somehow you have to put something in place to allow people to distinguish between trustworthy and untrustworthy sources. And they could be guides, you know, but the real long-term solution is to get people to start thinking in a skeptical way with certain basic principles of what distinguish between trustworthy and untrustworthy sources.
Yeah. So that brings us to the question of inducing people to think, inducing them to be skeptical and to question things, as Socrates said. I see in this meeting there are a lot of medical students and residents and young doctors in this meeting. We are almost at the end of the allotted time, Dr. Gayat. Do you have any words of wisdom, or do you want to share any advice with these young physicians, budding people?
Well, my conflict of interest in giving out advice is obvious, but I would say the more you can learn about evidence-based.
Oh, I think you got muted, Dr. Gordan.
The better. And there.
Yeah.
Yeah, okay. It's okay. Yeah, thank you, Dr. Gordan. I think we have your time. What you have allotted to us is, if you have any time, any of the speakers can ask something if you have time. Yeah. Yeah.
I'm very flattered that people have actually hung in there. So it's been a pleasure for me. It's been lots of fun. Thanks very much for giving me this opportunity to talk to you.
Just a quick update of Kotal.
Okay. Yeah.
Yeah. The evidence-based medicine is actually the sort of a science of the medicine. And,
Yes, I would agree.
And also we got the art of the medicine, which is the sort of a personalized medicine or a customized medicine. So when we integrate the evidence-based and the customized medicine becomes a sort of a integrated medicine, wherein we need to modify according to the wants and the needs of the patient or the person and their family and other associated. Just a sort of the sharing what I wanted to do. Otherwise, very nice to listen to you, and thank you for all of you.
Thanks very much. I do have to run now. Once again, been a great pleasure talking to you, and thank you for giving me the opportunity.
Yeah. Thank you, Dr. Gordan, for spending time with us and taking this session forward. Over to you, Dr. Kotur. Sir, you're muted.
Dr. Gordan got disconnected.
I think he had to go somewhere, he was saying.
Yeah. Anyway, what he said is nobody had listened to him for such a long time. We have a unique opportunity. Wonderful, he has so openly told so many things. It's quite good. We feel satisfied when we organize something, and if the participation and the effects come or the benefits come out of it, certainly we'll have some association with him. That's what I already talked. I don't declare now some with him. I thank all, especially the people from Australia, Basaraj. So it's nice to have them. Thank you, Dr. Bhatt, Dr. Ambujam, and Dr. Mahalakshmi. Thank you very much. Already 6:30. He spoke continuously for 2 hours, no?
Yeah.
Well done,
Thank you very much.
Good.
Thank you very much, sir. Yeah. On behalf of the Scientific Society of AVMC, Constituent College of Vinayaka Missions Research Foundation, I thank Professor Gordan for his valuable time. I thank Professor Kotur for getting Dr. Gordan not once but twice. And I also would like to thank all the participants who had sent the questions in the first round, in the chat box, and again in the second time when we announced. So we had actually we had to wade through a lot of questions, as Dr. Kotur told. We had 150 odd questions which we had to do. So some of those questions, though excellent, might have been missed, but I hope that we had done a fairly good job of trying to sort out and get the most out of Dr. Gordan's time. So with this message, we'll close this. But I have a message for you. We'll be back next Friday. We don't have FFF webinar tomorrow because we conducted this event today. So this Friday, we will not have Forefront of Future Frontiers webinar. So the next webinar will be on 9th of July. That is on Friday. 56. And we'll come 9th. 56th episode, I think. Yeah, 56th episode. Yeah. So we'll come and meet you on that episode with a very interesting talk. And till then, please stay safe. Take care of yourselves. Bye-bye. Thank you very much.
Thank you. Bye.